Welcome to Surviving Society's collaborative series with the Centre on the Dynamics of Ethnicity, based at the University of Manchester, also known as CODE. In these episodes, we explore the facts and evidence produced through the Centre's leading research. We ask how changing patterns of inequalities relating to the ways in which ethnic identities are perceived, acted upon and experienced in Britain. Across the series, we focus on policy and debates around ethnic diversity, integration, immigration and inequality. Welcome to another episode of Surviving Society's collaborative series with CODE. I am really excited today to be joined by Dharmi Kapadia, or Dr. Dharmi Kapadia, who is a senior lecturer in sociology at the University of Manchester and also you are part of CODE as well, aren't you, Dharmi?
Yes, I am, yeah.
Yes. Such incredible people at CODE, honestly. I'll never get over how many of you are in that within that network and centre. It's incredible. And Dharmi, your research interests focus on mental health, racism, stigma and older people. That's correct, isn't it?
Yeah, that's right. Hi, Chantel. Nice to be on the Surviving Society podcast. I've listened to so many of them, so it's nice to be on one. Thanks for inviting me.
Dharmi, you're definitely one of the people that gets cited a lot on this show, and it's just crazy that this is, like, after 7 years, you're only just coming on. So I must apologise to listeners because Dharmi's a serious scholar, and, like, your work is so important for, like, generations to come, but also in terms of how we understand the past and contemporary manifestations of inequality. Like, your work is so important. So yeah, thank you so much for agreeing to come on. And about bloody time.
No, it's no worries. I wasn't thinking anything of it that hadn't been on yet. I was excited to come on, and it was really good when CODE decided to do this collaboration, because I think there's so much stuff that we do at the centre, stuff that I do, and as you said, loads of my colleagues who I love working with. A lot of their work maybe became more important in the public eye after the COVID-19 pandemic, when people started, paying a bit more attention to racism. Mm-hmm. Obviously, lots of people like us were already paying attention to it, but I think it came on people's radar a little bit more after that.
Definitely. Like CODE's reports that we've kind of been circulating alongside of these episodes, both in season 1 and season 2, are just so clearly written and so important for this kind of post-lockdown era, where we're really looking at, like, ethnic inequalities with regards to how the pandemic was happened, but also how those ethnic inequalities map onto what was already happening as a result of kind of histories of class antagonism, but also austerity. So yeah, you're so right. Like, it's never been more important to, like, circulate research and information that institutions and centres like CODE are putting together. So yeah, brilliant stuff. Dharmi, I guess it would just be really great for the listeners to hear a bit about your background. Like, how did you get into this work? Like, what was it that informed your kind of trajectory as a scholar specialising in racism and stigma and ethnic inequalities for older people as well?
Yeah, so I kind of fell into academia in a way because I never set out to work in academia. So I was one of these people who was a university dropout, college dropout, as Kanye would say. Maybe we shouldn't really cite him on this show. He's a bit out of kind of popularity now, isn't he?
He is, but we'd got to put respect on that college dropout album. So we can cite.
That's an album.
Is an album. Yeah.
Yeah. So I went to university to study maths and philosophy, actually. And
maths and philosophy. Oh my.
Yeah.
Wow.
Yeah, and I actually dropped out after a year and a half. I found university really difficult, actually. Just being away from home, and I'd always been really good in in my subjects, in my studies, and I found it really tough at uni. And I dropped out, and I came back to Bolton, which is where I'm from. And I just started doing some temping jobs. So I did some temping jobs at the local Bolton Council, within some NHS settings in the area. And then I ended up getting a job working at the University of Manchester on a research study looking at the effectiveness of a new communication treatment for children with autism. And that job was actually as a research secretary and data manager, because I didn't have my degree then. So I started working on a research study, and I really enjoyed it. I really enjoyed working with the data. I really enjoyed that we were doing something that could potentially help families who, got kids with autism, help make family life better. And at the same time, I started doing my degree in psychology part-time with the Open University. And as I kind of did my degree and kind of got that degree, I wanted to continue working in research. So I worked on some other research projects at the university, and I thought, you know what, I actually really enjoy doing research. I'd love to stay in it. And that's when I did my master's and PhD. And that's when I really kind of started to look in the area of inequalities for ethnic minority people. And my PhD was about inequalities in access to mental health services for women of different ethnic groups in the UK. And that was using some survey data sets. So, large scale data sets that we can do quantitative analysis on, because I'm trained as a quantitative social scientist.
Incredible.
So that's how I kind of got into academia, and then I've just stayed since then. But I think sometimes it's quite important to tell people what your background is, because they assume that we've all come from, this normal trajectory of how you get into academia, and that wasn't my experience coming in. And I think, my work experience, life experiences helped me to think about what I would actually like to do, and then, and use that in my work as well.
That's amazing. So then, you get the PhD, you do the work on ethnic inequalities for women accessing mental health support. What are some of the findings that you see?
So in that
and if you don't mind
piece of work
sorry, Deb, if you don't mind me asking, what year are we talking here, just so I can map it onto the politics of the time?
Yeah, so I did my PhD kind of 2012 to 2015, but I used quite old data to do my research. So I used some data from the year 2000, because as some of your listeners might or might not know, there's not some of the data that we have in this country for ethnic minority people, it's not that good. So when I was actually trying to find data sets where I could look at mental illness, use of mental health services, and there were enough ethnic minority people in there, this was the only data set that I could find at the time, and it was from the year 2000.
Wow.
And the findings in that data set showed that Pakistani and Bangladeshi women in the UK were less likely to access mental health services. And this is something that when I said mental health services, it was kind of like outpatient mental health services. So seeing your GP for a mental health problem, or seeing a counsellor or a psychologist. So it wasn't inpatient services like using a psychiatric inpatient unit, for example. I think we're always, give a bit of a caveat or a bit of a, warning about research that it was quite old data. But as I said, it's because there was no data sets that had enough ethnic minority people in it that I could actually look at use of mental health services. So that there's a huge survey in the UK called the Adult Psychiatric Morbidity Survey, and it's done every 7 years. So it's currently the most recent one is being done this year, 2023. But before that, it was kind of 2014. But there's not actually that many ethnic minority people in it. And that asks about, mental illnesses, use of services. But I actually couldn't use it for my research at the time because there was very few ethnic minority people in it. Although the most current survey is collecting an ethnic minority boost sample. So they're oversampling, they're making sure there's enough ethnic minority people in there. So when it's released, hopefully next year or 2025, we can actually do some analysis that kind of interests us about inequalities for ethnic minority people in mental health services.
Amazing. So you finish that work and then you're like, okay, older people. How do then we get to older people from your work on women and ethnic minorities?
Yeah. So I think I was still interested in kind of mental health and mental illness and mental health services, but I was also working with some colleagues like James Nansrew and Laia Bikaris, who were doing some work on ethnic inequalities for older people. So this is kind of based on, so we know there's lots of ethnic inequalities in health services, generally in the, general population, all adults. But then when you kind of get to these older ages, actually some of the inequalities are worse at these older ages because, disadvantage has been what we call accumulating over the life course. And then by the time you get to these older ages, things could be very bad for older people in terms of either their health, the housing they might have, the opportunities they've had, the wealth they've been able to or not been able to accumulate over that time. So I was working with colleagues and we thought that this was an area where there was very little at the time, partly due to lack of data, partly due to people in the race and ethnicity field not really paying attention to older people, but also the same happening in gerontology field, so the field that looks at older people. So that, they weren't really coming together, the gerontology and the race fields, to say, actually, what's it like in the middle for ethnic minority older people? So, we got this funding from the Nuffield Foundation. So that was Laia, James, I, and Sarah Stopford, who works at the University of York, to look at what things are like for ethnic minority older people. And we had to do some quite innovative things with data to get at that. Because, I was just talking about, there's a real lack of data sometimes. We had to think about how we can put different data sets together, do some quite, innovative statistical methods to make sure we can actually do some robust analysis. And we've actually written an editorial in the British Medical Journal, which is considered one of the best health journals in this country, saying that the fact that we don't have these good data for ethnic minority older people is a form of institutional racism. Because if people consistently or, you just can't find data about them in these data sets, then how can we actually measure what's going on for them? So, when people are designing a new survey, if you're forgetting to make sure that there's older ethnic minority people in there, and if you're not asking questions that are relevant to ethnic minority older people, so for example, asking about racism that's happened to them over their whole life course, if you don't have those two things, then how can you really figure out what's gone on for these people and why things are so bad for them?
And I guess, just speaking really frankly, Dharmi, one of the things that this series and working with you guys as researchers at Code has really pushed me to think about is kind of aspects of lived experience and racism and mental health that I think I've in the past had kind of ignorant views around mental health and ethnic minorities. And I think those things are kind of passed down and they're structural and they're framed by Eurocentric notions of madness or disability. And I've had to really look at myself in terms of thinking about how mental health manifests for ethnic minority people and how that's different, but particularly for older people. And it's in my head, well, older people don't have mental health because they just get older and then that's it. I can't say that I haven't had those kind of it's not that I've necessarily had views, but it's kind of been an absence of understanding that I haven't paid close enough attention to. It's you can have an awareness of inequality, but actually there's a very specific form that you've just been talking about that if we only know what we know. But I think for me, not knowing meant I kind of had an ignorant view around what is actually happening. And
I think we all have to challenge our own stereotypes or own kind of just automatic thinking or things that have been passed down to us from family. So I don't, I think that's just a normal thing that happens to people. And then we have to kind of critically think about, well, actually, do I accept that? Or does that make sense? Or do I not need to think about that a bit more? And I think when we think about older people as well, some of the work, so I've talked a lot about kind of survey data and kind of what's available, but we've done quite a lot of qualitative work as well with older people. And we did some interviews during the pandemic to see how older ethnic minority people have been affected by the pandemic. And as part of that, we asked them about their experiences of racism over their lives. And, they gave us numerous examples of how racism had affected them. So how they'd been affected in their jobs, some who had migrated to this country facing racism in jobs in nursing, jobs in factories, other settings as well where they'd faced racism. But they also talked about the racism that their children now faced and their grandchildren, and how they were trying to almost train generations in a way that they wouldn't then be even more disadvantaged. So obviously they knew that their children and grandchildren will be subjected to racism, but almost trying to help them navigate it so that there wasn't even worse effects of it. And we've found, colleagues of mine have done work that shows that these experiences of racism have a direct impact on health, they have a direct impact on mental health, and they have impacts on, what kind of job you'll end up getting or how much money you're able to earn. And it's important to think about racism not just as this like one-off event that happens to someone. We're not talking about being assaulted, or we're not talking about verbal abuse. Those things happen, but we're talking about those things happen for some people many times over their lives. And in addition to that, we've got institutional and structural racism, which is also impacting on people. So I think this is, when we're thinking about older people, these are all the things that need to be taken into consideration as to what has happened to people. Which means that they may not have great pensions later on in life. They may not have great housing. They've probably got lower life expectancy. So all of these things, that this much bigger picture is needed when thinking about older people and how things are for them.
100%. And I think, like whilst we're being open about like learning and understanding and how that's kind of a journey in itself, I do think that like for us, like as people of colour, as Black people, we do have also a long history of not necessarily being able to having the space to talk about our mental health in a way that is valued or considered worthy of support. So I think there's like structural things going on, but then I also think there's things like with us that relate to kind of healing and openness and intergenerational conversations, as you say, that like I think tell an important story about all of this work.
Yeah, and it's a really, from my perspective, this talking about mental illness and ethnic minority people and how racism has affected them, sometimes it's quite a difficult thing to think through properly and actually make sure what I'm saying actually matches up to what people think is happening to them. So I think on the one hand, we've got irrefutable evidence that says that ethnic minority people are treated worse by mental health services. So we've got evidence that shows that Black people are about 4 times as likely to be compulsorily detained in a psychiatric unit compared to white people. They're much more likely to go into a psychiatric unit with police involvement than white people. And that's the same for South Asian people as well. So we know that there's these kinds of, really harsh inequalities. And a report that I did with colleagues, which was commissioned by the NHS Race and Health Observatory, which has been set up specifically to look at ethnic inequalities in health and healthcare. In that report, we did a big review of the evidence. And we also showed that, Black people are more likely to be restrained when they're in psychiatric inpatient units as well. They're less likely to get access to talking therapies compared to white people. They're more likely to be subjected to injectable psychotic drugs. So this is, fire injection, being given medication for mental illness compared to white people. So, I could list more and more things that show that Black, Asian and other ethnic minority people are treated worse than white people in mental health care. But then at the same time, we have this narrative that people are not going to get help from mental health services, and that's why they end up being more ill sometimes. But why would people go and get help if this is the help that is available?
Yeah.
And this is what happens to them. And I think some of my work as well, I wrote a paper recently on stigma.
Yes.
So it was all about how there is a big narrative in this country and in other countries as well that there's more stigma in ethnic minority groups around mental illness, kind of things that we've just been speaking about as to like why people might not want to talk about mental illness in some ethnic minority groups, why they might not want to go and get help. And I think there's a big narrative that it's all about culture. So ethnic minority people's culture means they don't talk about mental illness and they don't get help. That's why they end up ill. That's why they end up having crisis services and, not attending to the problem when it maybe was like less severe. And this narrative has been it's kind of quite prevalent in, health professionals, in ethnic minority people themselves as well, amongst charities that help in ethnic minority groups. But actually, if we have that narrative, it just assumes that the blame is on ethnic minority people and it's their fault. Like, it's their culture, and it's a very reductionist kind of explanation. Actually, the reason why people don't go and get help is because of the state of some of these services and how they've been treated in the past and how their relatives and friends have been treated by some of these services. So I think, it's very important to talk about mental illness stigma more generally. But to say that it's the main reason why ethnic minority people don't get help, it's actually, I think it's more detrimental than helpful to getting people the help that they might need.
That's amazing. Dharmi, like one of the words that's just coming into my head is around trust, and how like there's such a systemic distrust based on lived reality and structural inequality that just manifests in all of these, like amongst all of these different subjects. Like there's such a distrust of the system because the system so often has been an unsafe space.
Yeah, and I think there's a paper that was written quite a while ago in the British Medical Journal called "There's More to Race Than Racism." And it was two psychiatrists saying that really we shouldn't keep talking about racism and mental health services because you're putting people off from, sorry, I'm just really paraphrasing here. You're putting people off from getting help from mental health services, and, that's not what we should do. And we've seen a very similar narrative recently from Kemi Badenoch, if I'm right, on a report that came out. Sorry, I can't remember all the details.
The Equalities Minister,
but it was a study it was like a historical study, an archaeological study, I think, that showed that ethnic minority people were treated worse. I can't remember the details. Maybe you can put the link on when you release the podcast. But, she said a similar thing, that we shouldn't be talking about these inequalities because it puts people off from getting help from statutory services. But if you can't acknowledge that statutory services have problems and institutional racism exists, you can't address the problem. You can't sweep things under the carpet.
It's just so appalling, like how inequitable healthcare is, but also how hard it is for so many to be able to live an ordinary and dignified life. And there's so many things in place to stop that from happening. And then you get people in like the highest office in the government saying, well, you need to just ignore these issues and just get on with it, basically. And it's like, I can't believe we're in an era where actually we're being told, stop talking about what's happening and just get on with it. Like, do you know what I mean?
Yeah, and I think we were talking about the work we've done on older people, and some of the older people we interviewed during the pandemic, and they were talking about getting the vaccine. So there was loads of narratives in this country around vaccine hesitancy, that ethnic minority people were being irresponsible for not wanting to get the vaccine, and that's how they were portrayed. We'd get these news reports about these people haven't had the vaccine and these people haven't had the vaccine. And when we spoke to people, like older ethnic minority people, they were saying, well, actually, there's a very good reason why some people don't want that vaccine. It's because there's lots of studies, scientific studies in the past that have experimented on ethnic minority people. You've got the Tuskegee, syphilis study. There's countless other studies. That, together with how people have been treated sometimes by healthcare services, does make people distrust things like a new vaccine, for example. But none of that was put across in the news reports, was it?
No.
When we were trying to explain why people might not be getting the vaccine. So things like that, where people's voices are really quite dismissed, and like history is dismissed as well. So I think that there is a lot of, people might say that, researchers at Code, we go on about the same thing all the time, but there's a reason for that.
You have to keep going, yeah.
Yeah, because we have to. And also our results from lots of research studies that we've do, they're showing quite similar things and for different populations.
Mm-hmm. Demi, could I just get you to return back to your points about stigma? I wondered if for the listeners you could kind of give a kind of little description on what we mean by stigma, because we've spoken about stigma a number of times on the show before, but not for a couple of years actually, like mainly with Imogen Tyler. But yeah, it'd be really great if you could just give us an introduction to stigma.
Yeah, so stigma, I think people who've studied sociology or, come across any sociological works, that stigma is always associated with Irving Goffman, a big American sociologist and ethnographer who did loads of work on stigma, and people are still talking about his work today. You can't really write a paper in academia without mentioning him. And he described stigma as like something that is really discrediting to a person. And it could be a physical mark, or it could be some information that someone knows about you that makes that person feel almost less than human, and it discredits them, and it doesn't give, and it means that they're not socially accepted in society or their local area or their community. And there's lots of different types of stigma. So you can be stigmatized due to lots of different types of things about yourself. So having a mental illness is one way that you might be stigmatized. So when I kind of teach stigma to my students, we talk about how the kinds of terms that are used about people sometimes with mental illness, that they're called crazy, psycho, loony, or people don't really want to listen to what they've got to say. But it can happen, to people who might be fat. They could be stigmatized because of that. You could be stigmatized because you live in poverty. So it's a really big idea in sociology, but it's something that we see in action every day. We see it happening around us. And for mental illness, so sometimes we think about like where this stigma comes from. And if you read a lot of the studies on stigma, they think about stigma coming from like this general public. So there's just like, it's the general public. They have stigmatizing attitude towards people with mental illness. But actually, if you think about it, stigma comes from lots of different kind of people. So it can come from your family and friends. It can come from, general public. It can also come from healthcare professionals. So some of the studies that I've kind of got, on my reading list for my students show that psychiatrists have very stigmatizing views sometimes about their patients. And patients who have very severe mental illness, if they've been diagnosed with something like bipolar disorder or a personality disorder, they're often treated in a way that you might not expect by psychiatrists and healthcare professionals. So sometimes they get branded as manipulative, as liars, as not really warranting these services because they're time wasting. So I think when we think about stigma and mental illness, it's not just what we might see, kind of in charities campaigns that, it's important to talk and we can reduce stigma by talking about mental illness. Actually, it's much bigger than that. It's like people have views about people with mental illness, and they can be quite different depending on who we're talking about, healthcare professionals or the public or family.
It's so powerful, I think, the concept of stigma, because I think one of the bits of stigma that I find fascinating, particularly thinking about Black subjectivity, as in Black personhood in particular, is how stigma can become socially reproduced by the stigmatized. Like the power of stigma is that it can shape how you see and view yourself and what you're deserving of, and like that's part of how power wins as well. That's part of how stigma continues, and stigma continues is because we start to believe it of ourselves. If you start to believe it of yourself, then developing the agency to see it as something that's been used to marginalize you, and it's not based on truth, it's based on myths and structures. Like, it's so powerful. Does that make sense?
Yeah, definitely. And I think, like in the field, you'd call it like self-stigma or internalized stigma, where those ideas and thoughts and lack of social acceptance that other people have about you, you just start to think them about yourself. So, you believe that what your employer says about you not performing at work, or you're not making any sense because of your mental illness, or you're not very reliable because you're ill. You start to believe all of those things, regardless of how, what might actually be happening. And I think within kind of the mental health field, people say that stigma sometimes can be more harmful than the mental illness itself. So that's definitely kind of what the World Health Organization and the World Psychiatric Association would say, that actually the harm that comes from being stigmatized is worse than the mental health condition. Because what happens to you when people know you have a mental illness is worse, which kind of brings up a massive question about, well, should we be diagnosing people with these labels in the first place?
Yeah, it's a big one, isn't it?
Yeah. Is there a better way? Because one of the things that we've seen much more of, say maybe in the past, maybe even past 50 years, is that we have a medicalisation of our lives. So increasingly we talk about our lives in a medical way. When we talk about mental health, it's medicalised. So we talk about mental health in terms of diagnoses like anxiety, depression, PTSD, ADHD, all of these kinds of terminology. They're just commonplace in our discourses. So people talk about mental, difficulties they have in these medicalised psychiatric terms, whereas in the past they wouldn't be talked about like that. So some people will say, well, this is a great thing because it means people are being diagnosed and can get the help they need. But some people will say we're actually medicalising ordinary human life, which doesn't need to be medicalised and it doesn't need to be treated with medication. It can be, we're actually putting our resources into the wrong place. We actually should be thinking about, well, let's go back to what's causing people to feel so stressed, or what's causing people to be suicidal. And a lot of those things are about poverty, austerity, lack of opportunity. So yeah, that is another debate as well, kind of within the mental health field, which I think is very important to be having currently.
Yeah, no, brilliant. I'm so glad we got onto that, Dharmi, because I think it's really important. Like, I myself am still grappling with like the politics of diagnoses, like as a sociologist as well. Like, we're very, like, we see the importance of structure and agencies. We see the importance of society in terms of the collective, in terms of the institutional, but we also see the importance in the individual and how that maps on. And in a society that we're currently managing, negotiating now, where there's so much inequality, like, it does make sense that a kind of tendency to individualize these things would even happen amongst those of us that would see ourselves as more quote unquote progressive. Yeah,
because it's very difficult to resist very powerful actors that are involved in this. It's very difficult to resist these big pharmaceutical companies that have billions of pounds to spend on advertising and schmoozing GPs and psychiatrists to make sure that their drugs go onto the market. It's very difficult to resist the World Psychiatric Association and all its kind of country organisations, like Royal College of Psychiatrists, that, do recommend psychiatric drugs. But then at the same time, it's difficult to say to someone that, well, you're not feeling very well, but there's no talking therapies available. It's only these medications. So if you don't want to go on the medications, there's not really any treatment for you. So I think it's a very difficult conversation, but we're seeing a massive increase and expansion in the use of things like antidepressants or psychotropic medication, but we don't see a decrease in mental illness.
No.
So then we have to think, well, what are the medications doing? We had an all-party parliamentary group which was set up to look at the harm of psychotropic medication, because a lot of people who try to come off them are experiencing kind of withdrawal symptoms. So kind of people talk about brain zaps and not being able to function if they're not on the medication. And this can happen for up to 50% of people. But these things were not really spelled out to people when they went onto these medications in the first place. So I think that all-party parliamentary group, it's been merged with another group, and it's a new group, like safety and medication. I can't remember the exact name. So this is a big concern at the moment about the quite widespread use of psychotropic medication, and whether that is the best thing for people who may be suffering.
Dharmi, this has been such an incredible conversation. Like, before we wrap up, could you present any kind of hopeful reflections about this work as we move into this next season, chapter of our lives as social researchers, but also as our lives as ordinary people?
Yeah, so I think you're right that a lot of what I've said feels a bit bleak.
No, it's not bleak. I think knowledge is power, and I think that there's some really insightful and thoughtful things that you've said, which actually in themselves are very liberatory. So yeah.
Yeah, I think so. If we think about racial inequalities for ethnic minority people in the UK, we did have some hope in that. So I talked about how ethnic minority people are more likely to be subject to compulsory detention in psychiatric units and being put into those units with kind of police involvement, which is not good for the people concerned. And we did have potentially a reform of the Mental Health Act, which was to try to redress some of those ethnic inequalities. And that, I'm not sure if that's going to go ahead, but it would be very good if those of who are in the field, so people like myself, people like psychiatrists, the Race and Health Observatory that I mentioned, if we could, keep putting that pressure on to think, well, let's really think about this, because this could really, it could really combat this problem, to think about how we reduce those ethnic inequalities. So I think that's one thing. I think the other thing is that even though some of us who do research feel as though we do research but nothing happens, I think our voices are getting louder and louder.
Yes.
So there's more people kind of maybe agreeing with us. Maybe not everyone we would like to agree with us. But, when we've got such good evidence, both quantitative, qualitative, other forms of evidence, that are showing these inequalities very strongly and very starkly, that can only give more strength to the arguments that we're making to do something about inequalities in mental health, in healthcare for older people. So I do think that, there's only so much people can ignore as such. And I think, there's so many of us in code, there's so many of us, other researchers such as yourself at other universities doing this work. I do think that some people are paying more attention now. And I think that's probably as hopeful as I can get, if I'm honest, Chantal.
No, it's good. It's good. As I said, knowledge is power. And yeah, we've just got to keep going, haven't we? Keep pushing.
Definitely.
Dharmi, thank you so much for joining us today. That was such an incredible conversation. I do feel uplifted, even though some of it is pretty bleak. Thank you so much.
Thanks for having me, Chantal.
And listeners, we'll be back again next week.
Thank you for listening to Surviving Society.
To support our work, you can rate,
review and subscribe. To host or produce a series of Surviving Society,
get in touch with us via Twitter or Instagram.